Now I invite Dr. Harvansh Lals to speak on nucleotomy. His front is ready with good wound construction, capsulorhexis and hydroprocedure.
I'll be going on nucleotomy. So as we all know that all other steps can be performed without any phaco machine. It is only for the nucleus removal that we need a phaco machine. And earlier on, there were a lot of techniques were described, flip and chip, downslope, internuclear when the phaco came. Ultimately, it became popular when divide and conquer came. What it meant was that we make a trench like this, divide it into 4 pieces and conquer. Divide and conquer. It has, before all the techniques were not reproducible. This technique had excellent reproducibility. Every time the steps were same. Little phaco energy was more, time consumed was little more. And if you see these pieces are little larger, because if you see the rhexis is over here which can assist 10-20%, when you try to prolapse and pull them out, sometimes they may tear the rhexis or you will have to divide them further. Then came a chopping technique where you bury the chopper, phaco tip and chop it. This reduces the phaco energy, this reduces the time and pieces you can divide as you wanted. But there was a difficulty in a very soft cataract, in a very hard cataract, and because at that time machines were not so good which can hold on to 400, 500, 600 vacuum, and we were operating in the range of 120 to 250 vacuum. So this direct chop was little difficult at that time. Then came the stop and chop, which is my preferred technique of phaco surgery or nucleus removal. Why we call it a stop and chop? You start as divide and conquer. That means first you make a trench, now divide into 2 pieces, now go into the chopping mode so that it is midway between the two, and it had an excellent reproducibility. And it can take all types of cases, whether it's a soft, whether it's a hard, a medium hard, very hard. So it has an excellent reproducibility. And most important, energy used while making trench causes no collateral damage whatsoever, because it is far away from the cornea, So even if your effective phaco time is little more than usual, you really don't have to worry. Whenever we are talking of the nucleotomy, we need to understand the anatomy of the nucleus, which is more conical backwards. So if your trench is horizontal like this part will not break. So whenever you want to make a trench, it has to go deeper in the center. And what are the steps which are required? We need to do the trenching, splitting, chopping and phaco aspiration. This is how we remove the nucleus. Now, what I call as a V-trench is my preferred method of trench. Instead of making a trench in the center, I make slightly off-center on the one side, then another trench on the off-center on the other side. If you can see, this is going like this in a V-shaped fashion. And then I rotate and make another V, or you can go straight, make it X or Y, little bit like an X and Y. It has to be V horizontally, it has to be V vertically. That means on the top it is wider. As I keep on going deeper and deeper, it may not remain as wide, because my aim is to have a central core broken over there. An important point again is that the hardest part of the nucleus is not the posterior most part. It is usually at the junction of, you can say, 3/5, 2/5 on the backward side, or maybe 3/4 on the backward side, depending upon the density of the nucleus. So whenever you are rotating the nucleus, take a counter pressure from the periphery of the capsule. So hold it over here, push it slide to the periphery and then rotate. Now go on to the other side and again try to make a V over here and go on that side. This is the video of pre-dye era. Again, because if you make a first central trench, when you try to widen, it keeps on slipping. So my initial strokes are going up to the end of the capsular axis. And now after some time you will see that you achieve full depth at the periphery while the center is not yet deep enough. You can see little bit of reflex coming from here now. The color has changed over here. So now if I keep on going over there into the periphery, there are more chances of PCT. Now my stroke, which was going up to this, is not going up to the full length on that side. So I now want to concentrate onto the center of this nucleus. And when you will remove the hardest part of the nucleus, suddenly there will be feeling of give way, and you will see a tongue-shaped tissue disappearing in front of it. If it happens, then you know that you have reached, cracked, or trenched the hardest part. And rotate it again, and once you have achieved that, my strokes became smaller and smaller. Now I am going to split in this method, where I go into the high vacuum setting, bury into the depth of the nucleus, and split it. Important point I will like to explain in splitting over here is that whenever you want to split a rubber band, if your hands are closer to each other, then you'll be able to split. Space required to split will be much less. If these hands are far away, then space required will be much more before it breaks. And space in the eye is a constraint. So your instrument for splitting the nucleus have to be closer to the tissue you want to split vertically as well as horizontally. That means if I split from here, when my both the instruments are superficial, I'll keep on dipping it without having a crack over here. But if my instruments are at the depth of the trench, at least one of them should be at the depth of the trench, if not both. And instead of dipping the periphery, if I try to lift the periphery upwards like this, it will crack very easily. So whenever you are splitting, and that is very important when you do the chopping maneuver, to keep your instruments closer to each other. So when we come to the chopping, there are certain terminology we need to understand. What is a vacuum seal? What is a central chop? What is a peripheral chop? And what is a modified peripheral chop? If you see this, when I say vacuum seal, I bring a tip close to the nucleus, nudge it, give a burst of energy with the phaco put position 3. Once it goes inside, stop giving energy, come to position 2 or aspiration mode, and hold it over there and lollipop put over there. Now the vacuum has been created around the tip and has been sealed. So this is a vacuum seal which is very important to hold, and only then you can chop. Then there is a peripheral chop, which was the initial chop design. This is a little cumbersome. You make a small trench over here for a vacuum seal. Put your chopper under the rexus margin, but it remains horizontal. Next, you create a vacuum seal. After creating a vacuum seal, turn the chopper vertical. After turning the chopper vertical, when vacuum seal is created, pull the chopper towards the tip. Once it comes closer to the tip, move it sideways to get a split. So this was little cumbersome and probably but was far more stronger than the central chop. Now you will see this. The central chop is when I do not negotiate my chopper beyond the rexus margin and I just bury it vertical towards the optic nerve or towards the vitreous cavity and pull this piece out. To get on a central chop, you will have to keep the chopper very close to the tip, otherwise it will tumble. So just in front of the tip or close to the tip, you put it over there. And if you are not able to get a full crack, then reposition your chopper and go into the depth. Bury it, this vacuum seal is created. Chopper has to be positioned close to the tip over here, not on this side. You can just bury it deep or start from the periphery, keep on going deeper and keep on pulling central. Try to separate it. If you are not able to separate, put your chopper deep again and always keep on increasing the depth of the chopper till you get a final crack. And once you have achieved this, another technique what I described as a modified peripheral chop is, instead of negotiating my chopper to the periphery of the nucleus, I bring the periphery of the nucleus outside the rhexis margin so that I can chop from the periphery, but I do not have to do the cumbersome steps of peripheral chop. So this is very useful, particularly for the second half of the chop. Because now there is enough of a space, the second half of the nucleus can easily be prolapsed. Now whenever you are having a grasp, again go below the center of the nucleus, just maybe junction of the 2/3 and 1/3 chapter towards the posterior side. If your grip is very superficial, now look at this. Now this chop is far more stronger. You don't have to reposition your chopper again and you can crack it in one go. But instead of negotiating the chopper behind the rhexis margin, I brought the periphery of the nucleus out of the rhexis margin. So once I have created a vacuum seal, I pull the periphery of the nucleus out and start from the periphery and chop. This I call as a modified peripheral chop. And then these pieces have to be crushed mechanically with the chopper if they are too large. And when you are crushing them mechanically, make sure that you do not crush them when your phaco is on. If you do not touch them with a vibrating tip. So just create a vacuum seal, keep it held over there, crush it and then suck it. If the pieces are small, their followability is excellent. They keep on coming to the center and can keep on getting absorbed very well. And always make an effort to be away from the cornea. If any time you are operating a cataract like this, and if you feel your machine is not one of the top quality, there is nothing wrong removing the phaco tip before removal of the last piece. Put on a viscoelastic, because as long as any piece of the nucleus is in the capsular fornices, the posterior capsule won't be able to come forward easily. When the last piece is out of the capsular fornices, now the capsule has more tendency to come forward. So if this time either you lower the parameter, or you could be a little more towards the cornea, or you even safer would be to put on a viscoelastic before removal of the last piece. I think we already said. Thank you very much. And this is our new headquarter building, which is more or less, this is a little older picture, more or less ready now. And this was the new book. I have edited the old book, which is now available. Thank you. And I invite Rajiv Chaudhary. He'll be talking about the IOL implantation.
Good evening, friends. Thank you, Dr. Harbans, for inviting us. As everything is now clear, the nucleus is out, cortical material is out, and now the chance is for the intraocular implantation. It is an easy procedure, but we have to keep some of the tips to be. The prerequisite of the perfect IOL implant is the well-centered anterior capsular rhexis, as Dr. Noshir has explained, intact posterior capsule, intact zonules, thorough cortical cleanup, well-vented anterior chamber, and in the bag implantation. With the 5, this is a photograph from Harbans' book. Can I have the point? You can see that chamber should be well filled with this viscoelastic so that your bag remain inflated, and the intraocular lens 5 mm, you can insert it with the 5.2 mm incision also. It should go with the deep bag, and this should go directly deep into the posterior chamber. Then the main important step in the intraocular is the rotation of or insertion of the upper haptic. It's upper haptic, it's to be bended, is not directly. If you bend directly, it will give the more pressure on the zonules, and there is the chances of zonular dialysis. So it is to be combined procedure with the bending of the haptic or dialing with the and rotation of the, I will show in the video. You can see enlarged to the 5.25, well center. You can see single piece Palma lens. Wash it, hold it from optic haptic junction. and insert without pressing the lip of the posterior lip of the wound. This will go in. Now the main important, this upper haptic should go in. So by holding with the rexis forceps and rotation and dialing together, this can very well go into the bag. It is very simple. Only thing you have to rotate and dial and bend it simultaneously. Then rotate it with the dial so you can confirm that your lens is properly in bag, and residual cortical material, if any, can come. Now we come to the using the forceps, single piece silicone, 3-piece silicone lens. This can be, there is a special holder folder, there is a groove here, you can hold with this, bend. It should be equal bend. Silicone, especially if it is moist, it can slip. Then it is holder with the lock, so you can, only important thing is to go up to 2/3 of the intraocular lens so that there is not be a widening of this become wide. So it should be equally folded on the, it's not a, so this is not good. Again, you can see that you can hold it. Now once you have folded the lens with the holder folder, inflate the chamber. With the holder folder, you require a 3 mm incision. You have done the phaco with 2.8, so slightly injured because there is with the width of the forceps. Now the same way you just insert and dial and rotate the upper haptic with the help of the forceps, and this is very simple, it can go. Then wash viscoelastic from the front and behind of the intraocular lens, that is an important thing. Then with the injector, the important thing that you give viscoelastic in the cartridge and in the front of the injector. Single piece hydrophilic lens. Take care that this loop should not come in between the cartridge. Properly press it with the blunt forceps so you will not injure to the, and take care that while closing the cartridge, it should not come into the lip of the cartridge. Then slowly inject. They are come with the spring action. So once you inject, release it. And then inject and release it. So that if by your plunger you are engaged the posterior part of the intraocular lens, you can very well easily dislodge. Push, release, then again push, release, and then you are ready for injection. Then, while injecting with the injector, the counter pressure is also an important thing. I will show that one of the problem when we not use the counter pressure, because there you are operating under topical or this eyeball knot is fixed. So sometimes with the pressure that eye will go down and your lens may open outside of the wound. Again, push the plunger, this lower haptics in the bag, and the procedure with the hydrophilic is very simple. Just you tape and this will go into the blade and dial and rotate. You can see the rexis is all well covered and lens is centered very well. Wash viscoelastic from the front and behind. This is you can have, this is probably the basic course, so not a part, but you can have the marking, toric marker in the slit lamp, or you can, in the sitting position, you can mark the 12 o'clock, 6 o'clock, 9. And this way you can inject the toric intraocular lens marking. Once you mark, so once you're done completed the phacoemulsification, it's very easy. Just inject. I will not go in detail because it's not a part of the course, but it's just because intraocular implantation. So you keep it the dial, then wash it. You keep slightly off center before washing the viscoelastic. You can see this mark. Then after washing the viscoelastic from behind, either under the IA, you can rotate it and try to keep chamber maintained. Once chamber collapse, there will chances of the rotation of the intraocular lens. I will leave the accommodative IOL. Now we can come to the problem during intraocular lens implantation. Sometimes you will open the both haptics into the AC. This can be you can see we are trying to the haptics is in antechamber. With the help of dialing spatula and hook, you re-inflate the antechamber, and with the spatula going underneath the capsular axis and dial the lens so that it will give you a guide. The spatula is going behind the capsular axis, anterior capsular margin axis, and then if you push it, this will go in. Same way you can do it for the upper haptic. Spatula should be underneath the capsular axis margin, and your lens can very well go inside the. Sometimes your lens is upside down. You can very well if it is open upside down, you can see that it is, and because they are the angled lenses, then it is important that should be properly opened. If they are not a zero angle, you can keep it at very well with the good inflation, trying to avoid the damage to the endothelium. With the help of a spatula and hook, you can very well rotate the nucleus. If there is I will take 1 minute, crack, sometime because of the injury with the cartridge, you can notice there is a crack. This lens has to be removed. This can be removed by cutting. You can see you cannot leave this lens like this. With the help of scissor, very well this can be removed. Keep your chamber maintained. Slightly you can enlarge up to 3.2, and these are hydrophilic. You can come with 2.8 and 3. Sometimes this is a broken haptic. This is a micro incision lens. One loop is engaged in the cartridge, which I mentioned that you should be aware that it should not be entangled. You can see there is one haptic with a part of optic is gone. It's very simple. Just you remove it with the scissor, and same with the 1.8 mm incision, you can remove this lens and again reinsert micro incision lenses. Now, one of the problem with this is with the small incision that you can, if you are not given a counter pressure, this lens is engaged in your wound. So you are half stuck. You cannot go inside. You cannot go outside. If you push too much, there is the chances of injury to the lens. If you pull too much, you will injure lens. So with the blunt, forceps gently and giving the pressure, counter pressure from inside, you can gradually insert the lens. But to avoid this, you should always give a counter pressure while injecting with the injector. I will. Now, one of two small videos. This with the sometimes this lens go with the jerky movement. That's you are not taken care. This can create the hyphema. That's very well absorbed, but this you have to take care with while injecting hydrophobic, especially the silicone lenses. They go with the. Now, one of the important steps, we are very careless once we have completed the surgery very well. We think that everything is completed. Lens implantation is very easy. And still we can rupture the posterior capsule. You can see you have to be careful that your chamber should remain. This is chamber filled. We are in 3.2, 3. Trying. There is a viscoelastic coming out. The chamber is collapsed. Still the surgeon pushing the lens, and there is created the tear here. So still you can create the tear while injecting the intraocular lens. You can see there is a rent, the vitreous coming. This is last video. You can see sometimes this newer lenses coming. We are not able to unfold. This is the post-operative. You can see this, they are giving tilt, and later on you can unfold post-operatively, causing the astigmatism. So you have to be careful while using this. This lens is unfolded, haptic is unfolded and remained there for a week till we noticed it and corrected it. So in short, meticulous surgical step, caution in IOL loading and injection, timely and appropriate intervention, we can give a successful surgical outcome. Thank you.
Many times we need to convert, then our surgical outcome, we should not induce so much of astigmatism, and how to really go for conversion. Dr. Sharad Patil from Nasik.
Yeah, so this is a kind of basic course, and many of the juniors or beginners, they want to convert from SICS to FACO, and someone who is already doing FACO at times need to convert from FACO to SICS or ECCE. So I will just cover some steps. Many of my earlier speakers, they have already covered most of the steps very well and very clearly with the videos. I will try to give some tips or some pearls to beginners by animation, and these animations were given to me by Dr. Debashish of Disha Hospital. So, someone who wants to start FACO from SICS or ECC, there is a nice article in AIOC in 2013 which gives you detailed outline how it can be done. So anyone who wants to convert to FACO initially, he should assist or scrub at least 300 cases. He must have some experience with ECC or SICS, some 20, 30 or 50 cases. One should study basic literature and pass the exam. Basic steps on 50 goat size, and learn this FACO in steps, in 5 steps. The step 1 can be IOL implantation, which is the easiest thing to do. Step 2 can be incision construction. Step 3 can be cortex removal. Step 4 can be capsulorhexis, and the last step, that is nucleus management. So if you go stepwise and conduct each step at a time and do at least 20-30 cases of each step, you will have enough confidence to go to the next step. So what we need is a good microscope so that we can see things very clearly, good and reliable FACO machine, so that one should know whether problem is with the surgeon or with the machine, and regular OT facility, 2 or 3 cases every session for 2 to 3 days in a week. And right eye is preferred over the left eye. Grade 3 nucleus sclerosis is ideal so that you can practice all this trenching and cracking of the nucleus. People should be well dilated, cornea should be clear, deep seated eyes to be avoided, and adequate lid exposures. The tips what you use for FACO, there are so many tips available, 45, 15, 0 degree. 45-degree strip is no longer used because it does more of a sculpting than trenching. 15-degree strip gives more occlusion than trenching, and 0-degree strip gives only occlusion, while as 30-degree strip is initially better for beginner because it is ideal for trenching. While doing trenching, your energy should equal the resistance from the nucleus. You can be dealing with the hard nucleus where you will use different kind of energy, and for soft nucleus you will use different kind of energy. And if you bury too much on the nucleus, you will do pushing over the nucleus without using adequate energy. At the same time, same thing, if you use less energy, you will do the same thing. While doing trenching, you should remember that more tissue should be trenched in the center and no energy should be wasted while coming back from the trench, and more energy should be used to trench the center. Since nucleus is tougher in the center, refocus microscope to see clearly all your steps. Remove small chips carefully during deep trenching, or you can blow hole in the periphery if you do not follow these steps. You can rotate from the periphery of the trench since you get bigger fulcrum and bigger rotation. While cracking the nucleus, use equal force on either instrument at the maximum depth of the tunnel. You can use pre-chopper to separate these two pieces. Don't use excessive force, otherwise you will cause strain over the zonules. Don't try to be superficial, otherwise you will not get the crack. Cracking can be initiated from one end of the trench, from periphery towards the center. If the crack is incomplete, you can rotate this nucleus by 180 degrees and complete the trenching and the division of the nucleus. Center is the hardest to crack, so you do not get good fulcrum also. So start always from periphery. Keep watch on side ports. Side ports should be at least 2 o'clock hours from the main wound, since it increases your maneuverability. And less than 2 o'clock hours side port can cause crowding of your hands and crowding of your movements as well. Tighter incisions will pinch the sleeve of the phaco handpiece and will reduce inflow of the fluid and will cause shallowing of the chamber and maybe burning of the wound. Keep watch on the surge. Here I am using 600 vacuum and 60 flow rate, so it can give me surge. Have a nice position of your hands. Have enough rest while doing all these steps. You should use all the fingers rather than using your wrist or elbow. So rest your fingers, little finger and ring finger on the forehead or on the temple side of the patient, so that you get enough control while doing the surgery. While impaling the nucleus or cracking the nucleus, it should be properly alienated. Tip should be properly alienated so that it can obstruct and you can get good vacuum. So if you can rotate this nucleus, alienate it with the tip, you can very well do cracking of the nucleus. If probe is too superficial, your hold is weak, and you can damage rhexis margin. Avoid always doing small rhexis. Small rhexis results in small trench, which is difficult to crack. Inadequate space for chopping, and you can injure rhexis at the same time. And small rhexis can always give fragment. Removal can be difficult, and fragment can remain hidden under the rhexis. And trying to hold the fragment may cause damage to rhexis or to zonules. Big fragment does not come easily through small rhexis. So once you keep in mind all these steps, in spite of that, you need to convert sometimes, and that can be due to difficult cataracts, runaway rhexis, machine problems, or impending nucleus drop. It can happen to many people. So this is a hydro procedure. Forceful hydro procedure can cause capsular rupture and nucleus can start dipping down. You need to convert in this situation. So in this case, nucleus is started dipping down. So you should be watchful and careful to bring this nucleus out. Either you can convert to ECC if you are comfortable with ECC, but it's an open chamber method. Vitrectomy can be difficult, and one need to take sutures which can induce high astigmatism. So in this patient, it's a hard brown cataract. So you can extend the same phaco wound to periphery and remove the nucleus through your regular ECC incision. Put a lens in the sulcus, take sutures. Many of the beginners can convert to ECC easily or SICS. Conversion to SICS, you can shift from 12 o'clock position to temporal side, or from temporal side, if you have started phaco, you can shift to superior side. You can include the phaco incision into SICS incision, but it is not a good idea since it makes wound unstable. So you can make a separate SICS incision. It's a regular step. Prolapse the nucleus in anterior chamber, either do hydrodissection or by your hook. You can use Vectis or whichever method you are conversant with to take it out. In this patient, as soon as I started doing phaco, nucleus has started dipping down. So you need to support this nucleus through pars plana, push it to anterior chamber, convert it to SICS, close your phaco wounds and take that out through SICS wound. That will save you a lot many complications of like nucleus drop or vitreous loss. One should always learn doing vitrectomy through pars plana. It is not a difficult thing, but it will help you to salvage many of your complications. And thank you.
Thank you, Dr. Ashad Patel. Now, if audience has got some questions, we'll be more than happy. Otherwise, I'll put the question to the panelists. If there are any question from the audience, we would like to handle that first. First question to Dr. Janin is, how to know that wound is tight? Once you finish the surgery, is there any way to find out the wound has been really tight?
There is a way to find out that your wound is well sealed, is you could just tap at the center of the cornea and see that it is not very tight. There's a little dimpling occur, not any fluid leaving the wound. If you're still not sure, you can put in a little air bubble and then see. If you feel the air bubble is not escaping, you don't need to take a suture, just wash, hydrate your ports, and then you have a well-sealed. Other thing is you can use a cotton bud and just tap the center to see it is a well-formed wound.
Can you put trypan blue to see whether the wound is tight or not?
I don't personally use trypan blue ever, but maybe you could, but I just see for the fluid leaving the AC or not. That's important because the outward and the inward movement is more important of the fluid.
So, as you know that the ingress of the fluid, when the patient squeezes, if the chamber collapses and when he opens the eyes, the fluid gets sucked inside. That is what causes endophthalmitis. So, we need to make sure that the wound is well closed at the end of the surgery. If you feel that wound is not well closed, what else can you do besides putting up a suture?
You could hydrate the wound more. More of a corneal hydration can be done. Make sure you have a lot of cornea, or put an air bubble and see that that wound is not leaking.
Another new thought process which is coming up is that because we usually hydrate onto the sides of the wound, so you can make a small nick at the center instead of putting full knife inside the center, maybe 0.5 millimeter or so, at the center roof of it, which is not perforated, and hydrate over there so that it gets compressed from the top instead of from the side. And
I add to the, instead of this, you can have 26 number straight needle and hydrate in the center.
Yeah.
Why going puncturing and
Yeah,
then hydrating?
even that is another option. But even 26 number gauge needle bevel is a little longer actually. You got to go a little more inside to hydrate. So you can do that,
With your
provided your wound is too large. But otherwise, just you can give a nick puncture with the 26 gauge needle or with a keratotome, a small 0.5 mm, and then inject over there.
I've got one more thought on this, that when you hydrate the wound, give it about 1 or 2 minutes, because what we do is we keep on hydrating the wound again and again and keep checking. So it's better to let the wound hydrate, because the stroma gets hydrated in another 1 or 2 minutes and then the wound gets sealed. So instead of trying again, give it about 2 minutes, just sit back, rest, and you'll find that the wound is sealed.
And, Dr. Naushe, do you vary your size of rhexis according to the density of cataract?
Yeah, I do. In very hard cataracts, I make a larger size of rhexis. Also in very soft cataracts, I know that sometimes it's very difficult to get into a bowl-like situation. So I would, in that case, also do a larger rhexis. In a posterior polar cataract or something, I would do a smaller rhexis, because I want the support of the anterior capsule in case we have a PC rent.
Also in cases where the rhexis has got a chances to run away, like intermittent cataract and epididic cataract.
That we do a smaller rhexis, and then we either do a smaller rhexis or we do a spiraling rhexis, which is much more controlled, and we do it with a 23 gauge system now rather than with a forceps.
So when we say small and large, it doesn't mean really small of 3 mm. A normal rhexis size is between 4.5 to 5.5. When we say small, that means we are targeting 4.5. When we say large, it is 5.5. Not that we are making 7 mm, or not that we are making 3.5 mm. Then is there... no, we'll keep on asking questions. We'll keep on asking. Because time is very short. So is there any difference in if there is a rhexis extension radial and a curvilinear? Do you find any difference in your management, or do you think they behave differently while doing phacoemulsification, Dr. Naushe?
It depends on where the rhexis has run out. It's subincisional or just opposite the phaco tip.
My question is, if it is a radial extension, when you open it, it goes just straight to the periphery, or there is a cone. Another is that when you are doing rhexis, it has gone out, which is little curvilinear. I mean, you are trying to make a rhexis which has gone out. So it's not a radial cut. And when you are doing a chopping, it gets torn into the radial direction. Does it make any difference?
A radial cut is definitely more dangerous, because it's going to go to the zonule much more quickly. The radial, the one which is a curvilinear one, also I'd like to point out that in these curvilinear ones, if you do not grasp the rhexis near the tearing edge and hold it a little away and give a swing, sometimes you do this thing, you could come back into the center.
Do you find any difference in bringing the rhexis in an older patient and in a younger patient?
I find that in a younger patient, you can apply much more force, and the zonule is strong, and therefore you can get the rhexis in quite easily.
My experience has been that it is much more tougher to bring the rhexis in a younger patient, because jonules are very stretchable. So when you try to tear them, jonules get stretched and keep them behind. They don't allow. But in an older patient, because there is hardly any strength in the jonules, so it is much more easier to guide them in if I have gone beyond the jonal attachment onto the anterior capsule. Now, Dr. Ashok Sharaf, when not to do hydro dissection?
If you have a posterior polar cataract, you should not. That is very, very important. And then when you have a zonular dialysis in, some part of the area, then you have to be very careful. If you do, then it will force the nucleus to go a little down. But the most important is posterior polar cataract.
So, if you like to enlarge this question, what do you think is the cause of the nuclear drops while doing hydrodissection? We need to be very careful in doing hydrodissection. Like posterior polar is one of the causes.
Yeah.
So it boils down to the mentally analyzing what are the factors which can lead to nuclear drop during hydro procedure.
See, in fact, in the case of posterior polar cataract, there is a congenital deficiency at that point of time level in the capsule. So when you inject the fluid with the force, when it goes between the cortex and the epithelium, then that force which we push the fluid, that will open up that opening, and then that will lead, that can enlarge subsequently.
Basically, whenever there is a posterior capsular weakness, there are three factors which are very important for this. One is we are injecting the fluid. If you inject the fluid too forcefully,
Yes.
and it has to come out of the anterior rhexis margin, or if it is not able to come out of the rhexis margin. So if there is a posterior capsular weakness, as in a posterior capsule, posterior polar cataract, in a high myopes, in a vitrectomized eyes, or even where it looks like a posterior subcapsular, but if it is a fibrous capsule, so there are more chances. Or when the fluid is coming back, the rhexis is very small, fluid may not be able to come out. Or if there is too much of a viscoelastic into the anterior chamber, so that can block the fluid coming out, so you can partially deflate. Do you always, Dr. Ashok sir, do you always rotate your nucleus after doing hydro, or you have stopped doing this step?
I always rotate if it is possible. I don't apply a lot of force, but if it is possible, initially and it becomes easy, then I do.
Do you always remove the epinucleus with the irrigation aspiration cannula? You use phaco tip also for irrigation aspiration?
At times, phaco tip also, at times, but
particularly
mainly coaxial.
Yeah, particularly in a very thick plate which was being shown over there, probably phaco tip would have been faster. And if there is only, when anterior extensions have gone, and only posterior epinuclear plate is left behind many a times, because there is an anterior epinuclear plate, posterior epinuclear plate, there is a junction at the equatorial, which sometimes may be very brittle, so as soon as you try to pull anterior epinuclear plate comes. So how do you handle if there is only posterior epinuclear plate?
If there is only posterior nuclear plate, that is very difficult, but what I do, I take out everything, put the visco, insert the spatula and try to lift up the posterior nuclear plate little interior to the or at the iris level, and then we take it out.
So the very important point which has been brought out over here is that pressurize the globe, pressurize. Because if you put a pressure, there is enough of viscoelastic, then you can slide the epinuclear plate, and anywhere you find a crack, put on a rounded iris suppositor behind that and lift it up. But it should be done strictly in a well pressurized globe. If the viscoelastic pressure is not there, then it may be very, very difficult to slide. Is there, Dr. Rajiv Chaudhary, is there any difference between hydrophilic loop and hydrophobic loop in an injector when we place? Like we use ammo, alcon, and then we use the hydrophilic loops.
Definitely, because hydrophilic opens very fast, and this hydrophobic single piece, they are comparatively more hard, and if they come with the pressure, as I have shown in the video, they can traumatize the iris and can cause hyphema, and that takes some time, especially in the cold temperature. They sometimes take more time to get open inside the eye.
So that is the reason we try to keep the loop on top of the optics in a hydrophobic and not in a hydrophilic?
Basically, hydrophilic is opens very fast, and they are very easily can be guided. But especially hydrophic and recently that coming, that Invista, they are more hard. They are glistening free lenses, but they are more hard, and sometimes they take more time to get open inside the eye.
So then we should inject it directly. Why we try to put it on top of the optics then?
You cannot inject, because then it is a hard, it will go directly like a hard loop, and it can tear your posterior capsule.
So it's a very, very important point that. Another is that because hydrophobic density is high, it can be easily go through a smaller incision and you can keep it on top of them. While hydrophilic density is not so much, that the lenses are thicker, you can't fold the loops on top of the optics. They have got to be kept as a plate haptic. But whenever the loop is coming out, irrespective of the type of the lens you are using, you need to observe that that remains horizontal all the time. So whether it's a hydrophilic, as a 3-piece or hydrophobic, they should not tumble inside. And this is where, because of the paucity of time, I'm not taking opinion of all the panelists. When you are using wound-assisted IOL implantation, and if the viscoelastic leaks, that can pose problem. So it has to be again done in a well-pressurized eye so that the loop can slip and it remains horizontal. Now, Dr. Sharad Patil, if you are doing temporal incision, if you need to convert, you will enlarge the same incision or you will go to the superior side?
It's always safer to go to superior side because converting a phaco incision, which is quite well inside the cornea, and again bringing it back, it is going to cause some problem and wound becomes unstable temporarily. So always safer to come superiorly. So you can have a fresh incision, and phaco incision can always be sealed even by hydro procedure.
How you convert a scleral pocket? And suppose you have made a superior, which as ICSs many times make, and you need to convert to ECC. How do you convert the scleral pocket into extracapsular cataract extraction?
You can go towards limbus from the extreme ends of your SSS incision.
You are already given a superior scleral pocket for 5.5 millimeter incision, and you have perforated 2.5, 2.75 according to the phaco tip into the eye. Now you find there is a PCT, or you need to convert. How do you convert that?
Yeah, you come towards the limbus from your SSS incision from the periphery.
What do you do with that pocket?
You can take sutures at these two ends of your...
and make another incision at the limbus.
Yeah.
So, but anyway, I usually prefer if you have made a pocket, as we used to do ECC TRABI, I don't know many of you have done or not. So I give a side cut, say if I have got a 3.2 millimeter incision, a side cut like this on both the sides, break the tunnel like this and open up so that now you can see where your internal wound is, and then make a gutter on both the sides and cut like ECC on both the sides. So that you suture the flap as you do in trabeculectomy, and they suture these two sides separately. So that way you get an excellent result. And if the piece is very small, then it is altogether different. With this, we thank you very much for all of you for being here for so long. Yeah, questions please. Questions will be more than happy to answer.
In the learning period of phaco, while doing trenching, we thought trenching is completed. We started dividing it. But while dividing, we came to know there's some soft nucleus, soft material in front of the hot cat plate. It is all damaged. Now finally, we got a plate of posterior cortical plate. How to manage further? The trench was not complete.
No, the nucleus is removed only if...
We started trenching.
Yeah.
We thought trenching is over.
Nuclear plate.
We started dividing. While trying to divide, some cases we are not able to divide further. The meanwhile, that hot substrate is totally consumed or damaged or soft, becomes soft. Now, finally, we got the plate of posterior cortical material.
I think
it's proceed further.
There are two important points which you have brought into this discussion is, as we were talking earlier on in my nucleotomy technique, that my peripheral trench are less deeper than the central trench. And it happens only when you have all trenches at the same depth and you try to crack, it is not cracking. One is taking a step at that time and retrenching. So if you are not able to trench it well, even if there is a partially broken, there is nothing wrong in trenching again. Now in the second situation where now you tried all the efforts and you tried to grab from the one corner and it came to your phaco tip. Then you went to the another place, it came to the phaco tip. So you kept on trying to chop it, but you could never chop, it becomes a plate over there. If the nucleus is large and rhexis is small, in that situation you will have no choice but to go and again try to make a trench over there. Carefully try to make a trench in the center or whatever part it is, because you need to have at least one piece out, whether by divide and conquer method or stop and chop method, and there is nothing wrong in making a small trench in the plate carefully and then separating in the center once again. But if the rhexis size is large, then you can put on a viscoelastic, shift the nucleus on the one side slightly, push it into the capsular fornices onto the one side, and then put on a rounded depositor or a viscoelastic cannula underneath the nucleus. Either you can put on a iris depositor which is rounded, straight away once you shifted it onto the one side, you get some gap between the rhexis and over there. You try to put on a viscoelastic over there first little bit, and then put on iris depositor and try to lift it straight away.
Then you have a kind of scaffold below the nuclear
you need to bring it out.
Mechanical support.
Yeah.
Thank you.
You need to bring. Yeah.
In spite of loading the IOL in the injector in the correct way, what are the possibility of getting it placed inverted? Did you got the point? In spite of correct loading of the IOL in the injector, is it possible that
this is possibility. If you loaded it, but instead of pressing from the center, if you press from the side, it will open in the reverse direction. And another possibility, you might rotated your injector.
In which way?
So it's become an upside down.
So how we can, while injecting, how we can check that we may not place it upside inverted?
See, this is what I was telling you. When you are injecting the leading loop, you need to observe always leading loop is horizontal, but it can still happen. And if it happens, then there is a question is whether we should reposition it or we should leave it.
So once you are inserted and you are in the cartridge, you are sure that you have placed from the center and lens is folding like this. But sometimes you are not sure. Then once you inject inside the eye, you should observe as Harbans has mentioned, the lower haptics first. It should be coming like the convexity downward and the clockwise direction.
The question is, if it opens reverse, should we now make an attempt?
No, that's coming to the point. See, if it is reverse opening at that point, you will be able to notice at that point also. You are not injected the full lens. You are seeing that the lens lower haptic is in the reverse direction. At that time, you can rotate your injector and the opposite direction. You can inject.
Even by rotating the injector, if only loop is left, it may not come back. So then quickly keep what I call as again rounded depositor is my favorite instrument, and it takes some time. So I will inject and immediately I'll go from the side port and try to lift it and try to re-rotate it from the side port. But in case it has gone back, if you feel comfortable, you can visco-pressurize the eye, and with the two instruments, you can make it vertical and rotate. There is not much of an issue. But if you feel uncomfortable, you can leave it as such. Maybe there is some change, 0.25 diopter in power change, but no major issue as such, leaving it other way around.
It is almost 2-3 diopter, not less than this.
But you can very easily can rotate, as I have demonstrated in the video, that with the spatula you can rotate inside the eye.
Sir, if hydrophobic silicone lens is broken while injecting the lens with optic and haptic junction, and we leave as such in the bag, what will happen?
See, that depends how much is the broken segment.
The whole haptic, sir.
Whole haptic?
Yes.
See, if whole haptic is broken, the chances of decentrations are comparatively higher. So,
sir, after 1 week post-op, there is no decentration. The lens is in the bag.
Then don't worry. Relax and enjoy. God has been kind. I was coming to the chances of decentrations are more if your broken loop is down. So because of the gravity. So if your intact loop is down, and then the decentration will happen towards the broken loop. So if the decentration is temporal, patient will notice it more. So keep your intact loop either temporal and down, so that if it at all there is a decentration, it is down, which can be covered by the pupil, and if it is a nasal side decentration on the other side, it can be covered by the nose. But many times, because particularly these lenses, sometimes they stick over there. If it is sticking there now, most likely it will remain stuck over there for the rest of its life. So nothing to worry if it has.
Sir, what about cylinder? There is a high cylinder in that patient.
No, see, you don't have to tell the patient. If patient is happy, you don't have to ask the patient or tell the patient anything, because the patient won't. If many times I have seen the lens lying half into the center, patients are happy, they have got a 6 vision. So this is a contrast, a spherical aberration, all those things. The patient is not aware of all those things, so don't make him aware. If patient is comfortable, then why should talk about it? If patient is complaining, and if you feel that his complaints are because of the IOL, because it's a monofocal IOL, which patient has got a good vision, and the another question which comes to my mind is if the patient got a high cylindrical, then do the refractive cylinder and a corneal cylinder. If you find there's a lot of a difference between the two, corneal astigmatism is 2 diopter and you are getting 4 diopter on a refraction, then of course the part of the cylindrical power is because of the lens, then you need to remove it. But if your corneal astigmatism and the total refraction is the same, and patient's vision is good, you don't have to do anything.
Sir, but the patient, we don't tell the patient, but our next doctor tells the patient, the lens khisak gaya hai. So that is important.
Any other question from the audience? So I thank you all very much for being so late with us. And now my book is here. If anybody wants to see it, wants to have a look, it's now available, which was not available for 10 years. So you can have a look into it if you want to. But otherwise, I thank all the panelists for being with us. Thank you. देखो मैं तो यहाँ बैठा, मुझे क्या पता क्या हुआ, क्या हुआ, मैंने कहा मुझे क्या पता क्या हुआ. अभी पता. हाँ हैं? अच्छा लॉक में you got it. पार्टी पहले जिताओगे तो पार्टी की, हरवाने की पार्टी लोगे यार.
हारने की हरवाने की नहीं.